Hello everyone. Today we are going to discuss about stroke. Definition. A stroke or cerebrovascular accident is defined as an abrupt onset of a neurologic deficit that is attributable to a focal vascular cause lasting more than 24 hours or leading to death. Progressive stroke. A stroke in which the focal neurological deficits worsen with time, also called stroke in evolution. Completed stroke. A stroke in which the focal neurological deficits persist and do not worsen with time. Transient ischemic attack. TIA. Clinical syndrome of rapid onset of focal deficits of brain function which resolves within 24 hours. Epidemiology. Stroke is the second leading cause of death worldwide. Most common cause of severe physical disability. Prevalence of stroke in India is about 1.54 per 1000, with death rate is about 0.6 per 1000. Incidence and prevalence of stroke is on the rise due to increasing adoption of unhealthy lifestyle and an increasing life expectancy. Stroke risk factors. Fixed. Age, gender, race, Afro-Caribbean, Asian, European. Heredity, previous vascular event, example, myocardial infarction, peripheral embolism. High fibrinogen. Modifiable, hypertension, heart disease, arterial fibrillation, endocarditis, diabetes mellitus, hyperlipidemia, oral contraceptives, smoking, excess alcohol consumption. These all are the stroke risk factors. This is a diagram of circle of Willis, which is the blood supply of the brain. Here you can see the anterior circulation and the other half is of posterior circulation. Types of stroke. There are mainly two types of stroke: ischemic, hemorrhagic. Let's discuss about ischemic stroke. First point, 80 to 85% of the strokes. Second point, arterial occlusion of an intracranial vessel leads to hypoperfusion of the brain region it supplies. Third point, two etiological types: A. thrombotic, B. embolic. Etiology of ischemic stroke. Thrombotic, lacuna stroke, large vessel thrombosis, hypercoagulable disorders. Embolic, artery to artery, carotid bifurcation, aortic arch, cardioembolic, arterial fibrillation, myocardial infarction, mural thrombus, bacterial endocarditis, mitral stenosis, paradoxical embolus. Thrombotic stroke. First point, Atherosclerosis is the most common pathology leading to thrombotic occlusion of blood vessels. Hypercoagulable disorders, uncommon cause, antiphospholipid syndrome, sickle cell anemia, polycythemia vera, homocystinemia, vasculitis, PAN, giant cell arteritis. Lacuna stroke accounts for 20% of all strokes. Results from occlusion of small, deep, penetrating arteries of the brain. Pathology: lipohyalinosis and microatheroma. Thrombosis leads to small infarcts known as lacunes. Clinically manifested as lacuna syndromes. Embolic stroke. Cardioembolic stroke. Embolus from the heart gets lodged in intracranial vessels. MCA most commonly affected. Arterial fibrillation is the most common cause. Others: myocardial infarction, prosthetic valves, rheumatic heart disease. Artery to artery embolism. Thrombus formed an atherosclerotic plaques gets embolized to intracranial vessels. Carotid bifurcation. Atherosclerosis is the most common source. Others: aortic arch, vertebral arteries, etc. Pathophysiology of ischemic stroke. Blood supply to the brain is auto-regulated. Blood flow, if zero, leads to death of brain tissues within 4 to 10 minutes. Less than 16 to 18 ml per 100 gram tissue. Minimum infarction within an hour. Ischemia leads to development of an ischemic core and an ischemic penumbra. Ischemic penumbra. Tissue surrounding the core region of infarction which is ischemic but reversibly dysfunctional, maintained by collaterals, can be salvaged if reperfused in time. Primary goal of revascularization therapies. Pathophysiology. Ischemia leads to energy failure, which leads to acidosis, iron imbalance. Acidosis and iron imbalance leads to intracellular calcium increased. Iron imbalance also leads to depolarization, which leads to high glutamate levels. Depolarization leads to intracellular calcium increased. Intracellular calcium increased, then cell membranes and proteins break down, formation of free radicals, protein production decreased. It leads to cell injury and cell death. Hemorrhagic stroke. Two types. Hemorrhagic stroke is further divided into two types. First, intracerebral hemorrhage, also called as ICH. The second one is subarachnoid hemorrhage, also known as SAH. It has a higher mortality rates when compared to ischemic stroke. Let's talk about intracerebral hemorrhage. First point, it is a result of chronic hypertension. Second point, small arteries are damaged due to hypertension, which is high blood pressure. Third point, in advanced stages, vessel wall is disrupted and leads to leakage. Other causes: amyloid angiopathy, anticoagulant therapy, cavernous hemangioblastoma, cocaine, amphetamines. Subarachnoid hemorrhage. First point, most common cause is rupture of saccular or berry aneurysms. Second point, other causes includes arteriovenous malformations, angiomas, mycotic aneurysmal rupture, etc. associated with extremely severe headache. Pathophysiology of hemorrhagic stroke. First point, explosive entry of blood into the brain parenchyma structurally disrupts the neurons. Second point, white matter fiber tracts are split. Third point, immediate cessation of neuronal function. Fourth point, expanding hemorrhage can act as a mass lesion and cause further progression of neurological deficits. Large hemorrhages can cause transtenotoral coning and rapid death. Clinical examination. First is history. Ask for onset and progression of neurological symptoms. Completed stroke or stroke in evolution. History of previous TIAs and amaurosis fugax. Second point, history of hypertension and diabetes mellitus. History of heart conditions like arrhythmias, rheumatoid heart disease, or prosthetic valves. History of seizures and migraine. History of anticoagulant therapy. History of oral contraceptive use. History of any hypercoagulable disorders like sickle cell anemia and polycythemia vera. Substance abuse, cocaines or amphetamines. Examination of a stroke patient. First point. The neurological examination is highly variable and depends on the location of the vascular lesion. Second point. Skin. Look for rashes, hemorrhages, limb ischemia, DVT, also known as deep vein thrombosis. Third point. Eyes. Look for diabetic changes, retinal emboli, hypertensive changes, arcus senilis. CVS. Hyper/hypotension, abnormal rhythm, arterial fibrillation, murmurs, valvular anomaly, raised JVP, heart failure, peripheral pulses and bruits, generalized arteriopathy, respiratory system, pulmonary edema, infection, abdomen, urinary retention, locomotor system, injuries sustained during collapsed with stroke, comorbidities which influence functional abilities. General features. First point. Most cerebrovascular diseases are manifest by the abrupt onset of a focal neurologic deficit, as if the patient was struck by the hand of God. Second point. The clinical manifestations of stroke are highly variable because of the complex anatomy of the brain and its vasculature. Stroke syndromes. First, stroke syndromes are further subdivided into three types. Those three types are: first, large vessel stroke within the anterior circulation of the brain. Second point, large vessel stroke with the posterior circulation of the brain. Last point, small vessels disease of either vascular bed. Middle cerebral artery. Stroke within the anterior circulation. The internal carotid artery and its branches comprise the anterior circulation of the brain, that is, the anterior cerebral artery and the middle cerebral artery. Sign and symptoms. It includes the structures which are involved: paralysis of the contralateral face, arm and leg, sensory impairment over the same area. Somatic motor area. Motor aphasia, which is motor speech area of the dominant hemisphere. Central aphasia, which is central suprasalivary speech area, and parieto-occipital cortex of the dominant hemisphere. Conduction aphasia, central speech area, parietal operculum. Homonymous hemianopia. After homonymous inferior quadrant anopia, optic radiation deep to second temporal convolution. Paralysis of conjugate gaze to the opposite side. Frontal contraversive eye field or projecting fibers. Apraxognosia. Agnosia plus apraxia of the non-dominant hemisphere, non-dominant parietal lobe, area corresponding to speech area in dominant hemisphere. Loss of topographic memory is usually due to a non-dominant lesion, occasionally to a dominant one. Apraxia is a neurological disorder characterized by loss of the ability to execute or to carry out learned purposeful movements. Despite having the desire and the physical ability to perform the movements, it is a disorder of motor planning. Agnosia, non-knowledge or loss of knowledge, is a loss of ability to recognize objects, persons, sounds, shapes, or smells, while the specific sense is not defective, nor is there any significant memory loss. Anterior cerebral artery. Deficits due to anterior cerebral artery occlusion. Occlusion of the anterior cerebral artery ACA may result in the following defects. First point: if stroke occurs prior to the anterior communicating artery, it is usually well tolerated. Secondary to collateral circulation. Second point: paralysis of the contralateral foot and the leg. Third point: sensory loss in the contralateral foot and leg. Left-sided strokes may develop transcortical motor aphasia. Fifth, gait apraxia. Sixth, urinary incontinence, which usually occurs with bilateral damage in the acute phase. Internal carotid artery ICA. The clinical picture of the internal carotid occlusion varies depending on whether the cause of ischemia is propagated thrombus, embolism, or low flow. The cortex supplied by the middle carotid artery territory is affected most often. With a competent circle of Willis, occlusion may go unnoticed or unnoticeable. When the origins of both the anterior cerebral artery and the middle cerebral artery are occluded at the top of the carotid artery, abulia or stupor occurs with hemiplegia, hemianesthesia, and aphasia. When the posterior cerebral artery arises from the ICA, internal carotid artery, a configuration called a fetal posterior cerebral artery FPCA. It may also become occluded and give rise to symptoms referable to its peripheral territory. In addition to supplying the ipsilateral brain, the internal carotid artery ICA perfuses the optic nerve and retina via the ophthalmic artery. In 25% of symptomatic internal carotid disease, recurrent transient monocular blindness warns of the lesion. Patients typically describe a horizontal shade that sweeps down or up across the field of vision. A high-pitched prolonged carotid bruit fading into diastole is often associated with tightly stenotic lesions. As the stenosis grows tighter and flow distal to the stenosis becomes reduced, the bruit becomes fainter and may disappear when occlusion is imminent. If the thrombus propagates up the ICA internal carotid artery into the MCA middle carotid artery or embolizes it, symptoms are identical to proximal middle carotid artery occlusion. Sometimes there is massive infarction of the entire deep white matter and cortical surface. PCA, posterior cerebral artery. Posterior circulation. Dysarthria and facial numbness. This is point number 1. Point number 2, ataxia and Horner's syndrome. Point 3, facial weakness, LMN. Hemiparesis. This is 4 point. 5th point, hemisensory loss. 6th point, hemianopia. 7th point, loss of consciousness. 8th point, diplopia, vertigo or vomiting. Clinical presentation. Thrombotic, HOTIA, stroke in evolution usually happens in early morning. Embolic, patients with known heart disease like IHD, valvular heart disease. Rapid recovery. Hemorrhagic, stroke in hypertensive patients with high BP associated with emotional excitement. Differential diagnosis. First point, space occupying lesion, also known as tumor. Second point, seizures. Third point, migraine. Fourth point, subdural hematoma. Fifth point, metabolic disturbance like hypoglycemia. Hypoglycemia. First point, that transient hypoglycemia may produce a stroke-like picture with hemiplegia and aphasia has been known for years. Second point, the wide use of bedside rapid laboratory testing for glucose now makes this easily detectable and treatable. The hemiplegia may resolve immediately with the administration of intravenous glucose, but resolution over hours is also reported. Space occupying lesions. First point, subacute or chronic duration of symptoms. However, some patients may present with acutely, probably due to bleeding into a tumor. Second point, associated with deep-seated bursting headache, projectile vomiting due to raised ICT. Seizures and post-ictal states. First point, traditional thought is that these post-ictal symptoms and manifestations of seizure-induced alterations in neuronal function that are reversible. Structural neuronal alterations are not present. The post-ictal weakness or Todd's paralysis usually follows partial motor seizures but may follow generalized seizures as well. Duration is usually brief but may last 40 or 48 hours. Summary: rapid onset focal deficit of brain function confirms stroke. Onset and progression will decide the etiology. Precise history of deficit will decide the site of lesion. Investigation objectives: first, to confirm the vascular nature of the lesion. Second, the pathological type of the vascular lesion. Third, the underlying vascular disease. Fourth, risk factors present. Investigation modalities: brain. First category, non-invasive. First point, CT scan. Second, MRI scan. Third, MR angiography. Fourth, Doppler ultrasound. Fifth, EEG. Sixth, PET. Seventh, SPECT. Second category, invasive. First, lumbar puncture. Second, contrast angiography. Cerebral arteriography. Third, CT angiography. CT scan. First point, mandatory initial investigation. Second point, hemorrhage appears instantly as a hyperdense area. Third point, infarct appears as a hypodense area. Fourth point, infarct may not appear before 48 hours. Fifth point, MRI may be done instead, but CT scan is more sensitive for detecting hemorrhage. Sixth point, diffusion weighted MRI is good for identifying ischemic lesions. Hemorrhage in CT scan, which was done for the brain. As you can see, the hemorrhage is present. Infarct in CT scan, brain. Underlying disease: cerebral vasculature, abnormalities like aneurysms or AV malformations, cerebral angiography, vascular imaging, MRA, CTA or Doppler. These are non-invasive. Cardiovascular, like myocardial infarction, atrial fibrillation, valvular diseases, etc. First, electrocardiogram. Second, chest X X-ray. Third, echocardiography. Fourth, transesophageal ultrasound. Fifth, Holter monitoring. Paroxysmal nocturnal arrhythmia. Sixth, blood cultures. Serum lipids for hyperlipidemia. ANA for SLE. MR angiography for arterial dissection. Lupus anticoagulant for antiphospholipids antibody syndrome. ESR, CRP, ANCA for vasculitis. PT, APTT, platelet count for bleeding disorders. Proteins, C and S for hypercoagulability. Treatment objectives: minimize the volume of brain irreversibly damaged. Second point, prevent complications. Third, rehabilitation. Fourth, reduce risk of reoccurrence of the stroke. Management of stroke. Recognize the signs of stroke. FAST. Face. Ask the person to smile. Does one side droop? Arms. Ask the person to raise both arms. Does one arm drift downwards? Speech. Ask the person to repeat a simple sentence. Are the words slurred? Time. If the person shows any of these symptoms, call 911 immediately. Management of a transient ischemic attack TIA. Medical management. If diffuse atherosclerotic disease or poor operative candidates, stop smoking. Concurrent medical problems to be addressed. Emboli from heart and other parts of cardiovascular system. A. Anticoagulants, heparin, warfarin. Heparin should be given IV, intravenous. Warfarin can be given oral. B. Antiplatelet drugs, aspirin, oral, taclopidine, diabetes, hypertension, hyperlipidemia. Management of a transient ischemic attack TIA. Surgical management. Carotid and cerebral arteriography stenosis. Mild to moderate, regular follow-up. Severe carotid endarterectomy. All above can be done only if there is relatively little atherosclerosis elsewhere in cerebrovascular system. Management of an acute episode of stroke. Airway. Maintain airway, prevent aspiration, keep nil per oral. Breathing. Maintain oxygen saturation more than 97%. Supplementary oxygen can be given. Circulation. Adequacy of pulse and blood pressure, fluid antiarrhythmics, iron drops. Hydration. Prevent dehydration. Give adequate fluids, parenteral or via nasogastric 2. Nutrition. Nutritional supplements and nasogastric feeding. Medication. Administer medication also by routes other than oral. Blood pressure. Unless indicated, heart or renal failure, hypertensive encephalopathy, or aortic dissection. It should not be lowered for the fear of expansion of infarct. Ischemic stroke. Maintain 180 by 110 mmHg of BP. Hemorrhagic stroke. Keep MAP less than 115 mmHg. Blood glucose. Insulin to treat hyperglycemia can increase infarct size. Maintain less than 200 mg%. Temperature. Early use of antipyretics. Pressure areas to prevent occurrence of decubitus ulcers. Incontinence. Ischemic stroke. Thrombolytics and revascularization. TPA. Alteplase 0.9 mg kg max 90 mg. 10% of dose. Initial IV bolus. Remainder infused over 1 hour. To be used less than 3 hours of onset of symptoms. For maximum efficacy. Hemorrhage to be ruled out. Neuroprotective agents. Antiplatelet therapy. Aspirin and statins act by inhibiting platelet aggregation and adhesions. Aspirin 200 mg single dose to be given immediately following diagnosis. If alteplase given, it can be withheld for 24 hours. Later, aspirin at a dose of 75 mg in combination with clopidogrel 75 mg daily for about 1 year duration. Anticoagulants. Heparins, warfarin. Heparins act by accelerating the inhibition of factor II and factor X of coagulation cascade. Warfarin antagonizes vitamin K to prevent activation of clotting factors. Decrease risk of recurrence and venous thromboembolism. Intracranial hemorrhage to be excluded before therapy. More useful if stroke is evolving. Hyperosmolar agents. Reduce cerebral edema. 20% mannitol IV. 100 ml TID. Oral glycerol if swallow is normal. Concurrent medical problems such as arterial fibrillations to be tackled. Others, pentosyphilin to be used within 12 hours. Neuroprotective agents. Hemorrhagic stroke. Control of hypertension. Control coagulation abnormalities, especially due to oral anticoagulants. Surgical decompression. Surgery for aneurysms and arteriovenous malformation. Antiplatelet and anticoagulants are contraindicated. Rehabilitation. Physiotherapy as early as possible. Initially, passive movements. Later, active movements. In every case, early mobilization. Prevent contractures, spasticity, and atrophy. Occupational therapy. Speech therapy. Improve quality of life with motor aids, leg brace, toe spring, cane, walking stick. Secondary prevention. Blood pressure control, diabetes management, lipid management, smoking cessation, alcohol moderation, weight reduction, physical activity, carotid artery intervention, antiplatelet agents, anticoagulants, statins, diuretics, and ACE inhibitors, angiotensin converting enzyme inhibitors. Complications due to cortical brain injury: immediate epilepsy, seizures, cerebral edemas, residual deficits from stroke, paralysis due to immobility, chest infections, pressure sores, deep vein thrombosis, pulmonary embolism, painful shoulder, urinary infection/constipation, depression and anxiety and aphasia can occur. Stroke units, a multidisciplinary approach. Immediate resuscitation, prevent complication and recurrence. Emergency 24-hour evaluation and comprehensive care. Improves neurological outcome. Reduces mortality. 1,000 patients admitted to stroke units save the lives of at least 50 patients at end of 6 months. Prognosis: ischemic stroke. Mortality rate in first 30 days is 8 to 12%. Can vary depending upon size, location, symptoms of the stroke. Time that elapses from the event to medical intervention: first 3 hours after stroke, that is golden period. Intracerebral hemorrhage. Mortality rate in first 30 days is almost 50%. Site and extent of hematoma also plays a role in determining the prognosis. Hemorrhagic strokes have a poor prognosis compared to ischemic type. Thank you.